Module Overview. At the heart of palliative and end-of-life care lies the alleviation of suffering, particularly in the form of physical symptoms that threaten comfort, dignity, and quality of life. Terminal illnesses such as cancer, advanced heart failure, chronic obstructive pulmonary disease, end-stage renal disease, and progressive neurodegenerative conditions often present a complex symptom burden. This module provides an exhaustive, evidence-based, and interdisciplinary guide to the identification, assessment, and management of key symptoms, with a strong focus on pain control. You will explore pharmacological, non-pharmacological, holistic, and ethical frameworks for supporting patients experiencing physical distress in their final days or months. This module aligns with international palliative care standards, including those set by the World Health Organization, WHO, National Hospice and Palliative Care Organization, NHPCO, and European Association for Palliative Care, EAPC. Learning Objectives. By the end of this module, you will be able to identify common symptoms encountered in palliative and terminal stages, understand the principles of total pain and multidimensional suffering, perform comprehensive symptom assessments using validated tools, formulate individualized care plans for managing pain and discomfort, administer appropriate pharmacologic interventions, including opioids, utilize non-pharmacologic techniques to complement medical care, address ethical issues related to symptom control, including sedation, engage families in symptom observation, reporting, and support. Section 1. Understanding Total Pain and Suffering. Coined by Dame Cicely Saunders, total pain refers to the interconnected dimensions of suffering, including physical, pain, breathlessness, fatigue, nausea, emotional, anxiety, depression, fear, social, isolation, role loss, family tensions, spiritual, existential angst, loss of meaning. Effective symptom control requires addressing all 4 domains, not just prescribing medication. Section 2. Most common symptoms in end-of-life care. 1. Pain can be nociceptive, somatic, or visceral, or neuropathic, may be underreported due to fear of addiction or being a burden, requires regular reassessment, e.g., every 4 hours. 2. Dyspnea, shortness of breath. Common in lung cancer, CHF, COPD, often worsens with anxiety, managed through oxygen, opioids, positioning. 3. Nausea and vomiting caused by medications, organ failure, or intracranial pressure. Requires accurate etiology to treat, gastric stasis, vestibular cause, etc. 4. Constipation. Very common due to opioids and immobility, requires laxatives, hydration, and dietary fiber. 5. Fatigue profound and unrelieved by rest. Managed through energy conservation, rest, activity pacing. 6. Delirium, acute confusion, hallucinations, agitation requires medication, calm environment, and family education. 7. Secretion buildup, death rattle. Distressing for families, managed through positioning and anticholinergics, reassurance that patient is not suffering. Section 3. Pain assessment tools. Numerical rating scale, NRS, visual analog scale, VAS. Wong-Baker-Faces scale, for children and cognitively impaired. PAINAD scale, pain assessment in advanced dementia. Brief pain inventory, BPI. Assess location, intensity, quality, duration, and pattern triggers and relieving factors. Impact on sleep, appetite, and emotions. Section 4. Pharmacological management of pain. WHO analgesic ladder, modified for palliative care. Step 1. Mild pain, paracetamol, NSAIDs. Step 2. Moderate pain, weak opioids, e.g. tramadol, plus non-opioids. Step 3. Severe pain, strong opioids, e.g. morphine, fentanyl. Titrate based on response adjuvant therapies, anticonvulsants for neuropathic pain, antidepressants, e.g. amitriptyline, steroids, e.g. dexamethasone, for inflammation. Key considerations: Always balance efficacy with side effects, e.g., constipation, sedation. Use opioid rotation if tolerance or side effects develop. Administer breakthrough doses as needed. Always include bowel care plans. Section 5. Non-pharmacologic interventions. Massage and therapeutic touch. Guided imagery, music therapy, and aromatherapy. Reiki or acupuncture, where culturally appropriate. Spiritual counseling and guided meditation. Breathing techniques and relaxation training. Use of hot-cold packs or physical supports. These interventions enhance comfort, control, and dignity, especially for patients with medication intolerance. Section 6. Ethical issues in symptom control. Double effect principle. Using medication to relieve suffering, even if it may shorten life, is ethical if the intent is comfort, not death. Palliative sedation. In rare cases of refractory suffering, monitored sedation may be used ethically with informed consent. Voluntary refusal of food or fluids may be a patient's right, not necessarily suicide. Cultural beliefs must guide how pain expression and medication use are interpreted and approached. Section 7. Family and caregiver involvement. Educate families on observing and reporting symptoms. Provide reassurance regarding medication safety. Engage them in non-drug comfort measures. Encourage their emotional presence as a healing tool. Documentation standards. Use pain charts and symptom logs. Record medication responses and side effects. Note non-pharmacological strategies used. Log ethical discussions and family preferences. Module summary. Module 6 empowers healthcare professionals to alleviate suffering at its source through accurate symptom recognition, skillful pain management, and ethical decision-making. When supported by both science and compassion, palliative care restores comfort, control, and humanity to the dying process.